Hello, my name is Allison Ritter. I am a student in Dr. Manning's medicinal chemistry class at Valdosta State University. My project is on the 2014 Ebola outbreak in Africa. Ebola hemorrhagic fever is a highly infectious disease that is making headlines worldwide due to its destructive potential. Our question, could it ever enter the U.S., has already been answered, with 2 infected Americans receiving treatment here. The question now could this deadly disease ever erupt in America and cause damage comparable to the multitudes of damage of that in Africa? This project will examine Ebola's overview, the causes, signs and symptoms, and treatment. And then we will look at the specific outbreak in 2014 in Africa and see what the CDC is doing to control it. I will start out with giving an overview of Ebola. The Ebola virus was discovered in 1976 near the Ebola River. It is a member of the family Filovirdae, more commonly known as a filovirus. Its reservoir and nature is unknown, although many suspect that bats and bushmeat, like monkeys and large rodents hunted for food, are culprits that introduce the virus into the human population. Ebola is an aggressive, often fatal illness, killing between 60 to 80% of its victims. Infections with the Ebola virus are characterized by immune suppression and a severe inflammatory response that damages vascular, coagulation, and immune systems. Once inside the body, the virus begins to slightly separate the walls of the capillaries, causing blood leakage, low blood pressure, and poor circulation, subsequently resulting in massive internal bleeding, multi-organ failure, shock, and ultimately death. A person infected with the Ebola virus may begin experiencing symptoms 2 to 21 days after exposure. Early diagnosis is sometimes difficult. The early symptoms are nonspecific to the Ebola virus and include red eyes and skin rashes. Later symptoms may include fever greater than 101.5 degrees Fahrenheit, severe headache, muscle pain, fatigue, weakness, diarrhea, vomiting, abdominal pain, and unexplained hemorrhage or bleeding and bruising. Recovery from Ebola depends on a patient's immune response to the virus. Those with weakened or compromised immune systems would have a more difficult time recovering from this disease. According to the CDC, people who recover from the infection develop antibodies that last for at least 10 years. Removing bodies infected with Ebola is a risky job. The burial team must be dressed properly with protective bodysuits, face shields, and gloves when handling these bodies. This gear makes doing anything quickly almost impossible. Once inside the home of the victim, the body must be chemically disinfected. The undertakers then prepare the body to be placed in a body bag. This is the most risky job. The team members are only allowed to physically come in contact with the body once, and that is to remove it from the ground and place it in the body bag. Everything in and around the site of the body has to be disinfected, as well as the outside of the body bag and the hearse that will transport the body to the morgue. The CDC prohibits autopsies on Ebola patients unless it is critically necessary. If an autopsy is necessary, the state health department and the CDC should be consulted regarding any additional precautions. No embalming should be performed on the body due to risk of occupational exposure. The body bag must not be opened at any time, and the remains should either be cremated or buried promptly in a hermetically sealed casket. The 2014 Ebola outbreak is one of the largest Ebola outbreaks in history and the first in West Africa. The initial CDC report recognized 4 West African countries affected by the disease: Guinea, Liberia, Nigeria, and Sierra Leone. As you can see from the tables provided by the CDC, travel-associated transmission has imported the disease to places like Spain, Senegal, and the United States. Poverty is the largest reason for the spread of this disease throughout Africa. Most African areas affected by Ebola lack proper isolation and treatment facilities, as well as lack proper resources to handle persons and remains infected with the disease. Improper sanitation also aids the spread of Ebola. The question, could Ebola come to the U.S., has officially been answered. Yes, it can. It was first seen in the summer via 2 infected American missionaries who were flown back to the U.S. for what proved to be successful treatment. Unfortunately, in September of 2014, the virus was unwittingly imported into the U.S. via a passenger of a flight from Africa. On September 30th, 2014, the CDC confirmed the first laboratory case of Ebola in the United States in a man, Eric Duncan, who traveled to Dallas from Liberia. When leaving Liberia, the man did not display any symptoms associated with Ebola. However, after developing symptoms approximately 4 days after his arrival in the U.S., the man sought medical attention at Texas Presbyterian Hospital in Dallas. Based on his travel history, the CDC recommended testing for Ebola. The man was put into isolation, and all persons in the close contact with him had to be monitored for 21 days. Unfortunately, the man passed away on October 8, 2014. The second case of Ebola occurred on October 10, 2014, when a healthcare worker at Texas Presbyterian Hospital who provided care for Duncan tested positive for Ebola. Her name was Nina Pham. After developing a fever, she was sent to isolation. Later, she was moved to the National Institute for Health Clinical Center, and she has since recovered and was discharged on October 24th. The third and final case to date occurred on October 15, 2014. A second healthcare worker in contact with Duncan tested positive for Ebola. Her name was Amber Benson. She was transferred to Emory Hospital in Atlanta, Georgia. 5 days before testing positive for Ebola, the healthcare worker traveled by air from Dallas to Cleveland and then back from Cleveland to Dallas on October 13th. The CDC worked to ensure that all passengers and crew on both of the flights were contacted, questioned, and arranged for follow-up if necessary. The patient has since recovered and was discharged on October 28th. The Center for Disease Control, or CDC, is most commonly thought of as our nation's keeper of health, guarding us against the spread of infectious diseases. Given the 2014 Ebola outbreak in Africa, the CDC has felt the pressure of responding adequately to the panic regarding Ebola and its potential for a massive outbreak in the United States. Since early recognition of the disease, the CDC began constructing national guidelines for Ebola public health preparedness in the case of an outbreak. These guidelines gave a strategy for planning the readiness for an Ebola response at a state and local level, as well as assisting the state and local public health officials in assessing their level of readiness for a potential Ebola response, including individual patients and persons under investigation. It also identified resources that will assist state and local jurisdictions in solving problems arising from an Ebola outbreak. After the second confirmed Ebola infection, and with the death of Eric Duncan, the first Ebola patient, alarm in the U.S. began to rise. Doubts of the CDC's ability to handle Ebola circulated in the media and fueled public panic. The CDC deployed a team of experienced staff to work with the state's health department and with Texas Health Presbyterian Hospital, where the first case was treated, and 2 other healthcare workers fell ill. Dr. Tom Frieden, the director of the CDC, said that going forward, the CDC plans to deploy response teams to any hospital in the country that confirms a case of Ebola. At Texas Presbyterian, the CDC has implemented a site manager to oversee aspects of the infection control, including ensuring that personal protective equipment is used and disposed of properly. The CDC remains confident that the disease will not become an epidemic in the U.S., and that they will continue to stay on top of Ebola until it is eradicated.